Yo, it's Mr. Eric, Thursday, November 18th, 2021. Now, today's another nursing shift day, so we're gonna get into it, but before we do that, I just need to talk about a couple of things. As a daily blogger and as a nurse, we're gonna be dealing with two issues. First of all, HIPAA. As a nurse, I have an oath to comply with HIPAA. That means I need to keep patients confidential. I can't be talking about patients in detail. So what that means here is if I'm going to be doing a daily blog about my nursing shifts, I'm not going to be able to give details about how my day went. I can talk about conditions in general, how they get treated, but anything specific to the patient needs to be left out. So if you don't want to listen to it just for that reason, well, feel free to not watch these daily blogs. Also, I'm going to try to put like nurse or nursing, something related to that in the title of these videos. That way you know what you're gonna watch. That way you could skip it if you're not really interested. If I don't do it, just harass me about it. I will try my best to change it. It's good to change things. If you don't change based on listening to people, well, you're a narcissist and nobody's gonna like you. Okay, so that's the first issue. The second issue is that when I'm on my nursing job, I'm not thinking about what I need to talk about later in the daily blog. What I am thinking about is the safety of the patients and how I'm doing, what I need to do next to keep myself moving and ahead of the game in the hospital. So when it comes time to recap everything that happened in the day, I can't think about it in chronological order. I don't know why my mind works that way. I kind of think about things in general. So if you want me to talk about stuff that happens at specific times, well, I don't think I'm going to be able to do that. I am sorry. If you don't want to watch for that reason, well, it's alright. I will try my best, though, to mix the two, alright? So give me a break. Okay, so now with that out of the way, let's talk about how today went. Yesterday, I took one patient. Today, I took two. Yesterday, I was working with my assistant manager. Today, I was working with my actual preceptor. My preceptor is a very nice woman, very good nurse. I'm happy to work with her. I told her straight off the bat today that I want two patients, and she was like, all right, let me give you some. So the patients are as follows with these conditions. The first one has some respiratory distress. They've been in for a while. The second patient has a probable infection that they need to do more tests on. So let's talk about the first patient, respiratory distress. They've been in the hospital for a while, dealing with respiration issues, such as not getting enough oxygen. So they've been on supplemental oxygen since they've been here. They were on nasal cannula, like 4 liters, weaned down to 3 liters, and the goal is to get them down to 2 liters, which is their baseline. Anytime you're dealing with somebody who has supplemental oxygen at home, your goal is to get them back to their baseline. If they're not at their baseline, they're not safe to be home. So if somebody at baseline is on 2 liters oxygen nasal cannula, they need to leave the hospital able to do their normal activities of daily living on 2 liters of oxygen. Obviously, there's going to be some stuff that gets deteriorated, like they won't be able to walk as far, they might not be able to do the dishes. However, if they get set up with some sort of assistance at home, or if they got family, well, it's okay, they can make an exception. I don't know much else about that, because that's usually like the case manager's job, the doctor's job, but as a nurse, your goal is to help somebody improve with their oxygen. So to help this patient today, what I did was I gave them the meds like Solumedrol and nebulizers. What nebulizers do is they open up the airways more. What Solumedrol does, it decreases inflammation in the airways. That way there's more room for oxygen and less cramped up space. Along with that, when somebody's on respiratory distress dealing with oxygen issues, we want to ambulate them if they can tolerate it. The goal with this patient is to get them to 2 liters nasal cannula. However, they're currently on 3 liters, so what I'm going to do is I'm going to wean them down to 2 liters, see how they do at rest. If they can maintain a decent saturation at rest, well, let's try to get them ambulated, walking around, and see what their oxygen does. So that's exactly what I do. I ambulate this patient, their oxygen drops, but we titrate their oxygen back up so that they can recover and see how they do, and then we titrate it down so that they can walk back and then see how it goes. Now the patient does pretty well. We keep them on the 2 liters for the rest of the day, and they maintain well, so it's all well and done. In terms of discharge, I don't think discharge is in the works. That's usually up to the doctor, so we're just going to wait on what the doctor says. However, I updated the doctor on how this patient did in regards to their oxygen saturation while they were ambulating in the room. So that's the rundown on the patient with respiratory distress. Let's talk about the next patient who has a suspected infection. Unfortunately, I don't feel comfortable getting too much into detail about like how they might have got the infection, because that might give away some patient identification. So what I'm just gonna say is they have like an entry point into their abdomen that could have led to infection, and they got some abdominal pain, and that ended up in the hospital. The one interesting thing I want to talk about with this patient is that they are on something I learned last week. They are on CAPD, continuous abdominal peritoneal dialysis. Now, like I mentioned last week, continuous abdominal peritoneal dialysis is the constant exchange of fluid in the peritoneum, in the abdomen, because the kidneys don't work, so you need to get rid of waste by having it go into the fluid and then draining that that fluid from the abdomen. So the goal with this patient was to get them started on the CAPD routine, which involves like 4 CAPD exchanges in one day. So like every 6 hours, they get an order to drain the fluid from the previous that was administered and then put new fluid inside them. The goal with each administration is to see how much comes out versus what goes in. So if less comes out than goes in, you may be dealing with a problem where there's too much fluid inside their body. So that's what happened today. The patient got really full at one point. They felt rock solid in their abdomen. It was a new symptom. So we had to figure out, work with the doctor to see what we could do next. The doctor ordered some pain meds to like deal with the fullness because it was causing some pain. But then the next step needs to be taken in determining like how much fluid to actually give this person on their CAPD. The cool thing about CAPD is that it's technically a sterile procedure. All the tubing of the CAPD could lead to infection, especially since all the fluids are going straight into the abdomen, which needs to be sterile. So when you're doing CAPD line changes, fluid changes, you need to keep it sterile. So you make sure you clean the catheter or the line before you change the lining. When you take the cap off the line that's attached to the patient and connect it to the one that's attached to the bag with the CAPD exchange, you need to make sure nothing touches it whatsoever. You need to make sure that when you take the cap off, like you're not touching that port, because if you touch it, you are literally putting some bacteria on it that could go to the patient. I honestly like learning about all this CAPD stuff. It was tricky for me to figure out by myself, by my preceptor with me, which made it nice and easy. That's pretty much it for the conditions. I don't really remember what else happened today. It's like all a blur, to be honest, but there was a lot of communication that was done with the doctor via an app called TigerText, which allows nurses and doctors to communicate easily without having to like page or call. So I learned how to use TigerText. I also learned how to assess and give certain PRN medications. That's a big thing you need to know when you are a nurse working a shift. You need to know what your patient's PRN medications are, which means as needed medications, because if they start to develop some sort of symptom like pain, you want to know what kind of pain meds may be available for them if they ask. So if you're a nurse, always keep the PRNs in the back of your mind. Other than nursing, I pretty much went home. On the way home, I had a phone call with somebody. Who did I call? Hey, I forget. I don't think it matters. But when I got home, I ate food and I actually went to sleep early because tomorrow I want to get a head start on what's going on with the books. I'll catch you tomorrow. Till then, peace.